Good afternoon, everyone. My name is Rachel Volpe from the New England QIN-QIO, and I will be your moderator for today's webinar, MIPS and QPP Year 3, the Recipe for Success. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of this presentation, and if you haven't downloaded the slides, I have put the link in the chat box for you to find them. Throughout the presentation, you can enter any questions at the bottom right hand in the chat box, and we will also take questions over the phone at the end of the presentation, and I will provide you instructions on how to do so at that time. Now I will pass this over to Kelsey and Tushara to get us started.
Thanks, Rachel. Hello, good afternoon, and welcome everyone to our webinar today, MIPS and QPP Year 3, the Recipe for Success. My name is Kelsey Baker, and I'm joined today with my colleague, Tushara James. So this here is just a disclaimer that while we work under a contract with the Center for Medicare Medicaid Services, or CMS, we at Health Centric Advisors created these slides, not for folks over at CMS. Since we are now in Year 3 of the program, we're just going to briefly cover how the MIPS program was created, as most of you likely have a pretty good understanding of this already. Then we'll cover the 2019 final rule changes, as well as giving folks the ingredients for the recipe for QPP success. We'll have some time at the end for questions, as Rachel mentioned, and please feel free to type into chat any of the questions, and just make sure you send it to all participants. So now we'll get started. So in 2015, a bipartisan legislation was passed, and it repealed the Sustainable Growth Rate, and this was called MACRA, or the Medicare Access and CHIP Reauthorization Act. 3 legacy reporting programs, so that's PQRS, or the Physician Quality Reporting System, VBM, or the Value-Based Modifier, and Meaningful Use, were combined to form MIPS, or the Merit-Based Incentive Payment System. So this slide demonstrates the 4 performance categories under MIPS for 2019. The first is quality. Quality accounts for 45% of your total MIPS score in 2019, and clinicians and groups must report on 6 measures, 1 being an outcome or high priority measure. The next category is promoting interoperability. This was formerly known as advancing care information in the previous 2 years of the program. Promoting interoperability accounts for 25% of your total MIPS score. And this performance category has had a complete overhaul done on it to make it a little bit easier to report on. So now there are 5 required measures that folks must report on for promoting interoperability, including the security risk analysis, and an optional 2 bonus measures. Also, folks must be on a 2015 certified EHR for 2019, reporting to the promoting interoperability. The next category is improvement activities. This accounts for 15% of your total MIPS score. And you must implement 1 to 4 improvement activities, depending on the size of your practice and the weight of the activity, for a minimum consecutive 90-day reporting period. And then there's cost. So in 2019, cost accounts for 15% of your total MIPS score. The 2 measures, MSPB, which is the Medicare spending per beneficiary, and TPCC, which is total per capita cost. Those are still included in 2019, along with 8 new episode-based measures. And remember that for the cost category, you don't have to manually submit any data. CMS will automatically pull that for you. So who is included in the program? So rolling over from previous years, physicians, including doctors of medicine, osteopathy, dental surgery, dental medicine, podiatric medicine, and optometry, as well as osteopathic practitioners, chiropractors, physician assistants, nurse practitioners, and certified registered nurse anesthetists are included. And newly in 2019, physical therapists, occupational therapists, clinical psychologists, qualified speech and language pathologists, qualified audiologists, and registered dietitians or nutrition professionals are now included in this program, and we will have some helpful hints for those new eligible clinician types. The low volume threshold for the MIPS program has changed slightly for 2019. So clinicians are included in MIPS if they bill more than $90,000 in Medicare Part B claims annually and see more than 200 unique Medicare beneficiaries annually and provide more than 200 covered professional services under the physician fee schedule. If they meet all these three criteria, they are included in the program, unless they're in their first year of submitting claims to Medicare and or are a qualified participant in an advanced APM. If either of those are true, they are not included in MIPS. CMS has included a new option for reporting, which is the opt-in option. So for a program year 2019, clinicians who meet at least one or two of the low volume threshold criteria can choose to voluntarily report to the program. So these clinicians who opt in would be subject to either neutral, a negative, or positive payment adjustments based on their MIPS performance and the final score. The performance threshold for 2019 has also changed. It has increased. So eligible clinicians and groups need to earn 30 points in order to avoid a negative payment adjustment in 2019. So you can see the increase here. Year one, we needed 3 points. Last year, we needed 15 points. And this year, 30 points. And there are a myriad of ways to get that 30 points. You could report on the improvement activity category, which will give you 15 points, and report on at least 6 quality measures, earning at least 5 points each, and that's out of 10, and it will give you just over 30 points. And again, it can be a variety of measures or activities to give you that 30 points. This slide here is to demonstrate the financial impact of the program. You know, we hear from clinicians that time is a real barrier to fully committing to this reporting program or any others. But we truly believe that putting the time in is worth it. In the first year of the program, folks were subject to either a 4% negative payment adjustment up to a positive 4% adjustment. Last year it was 5%, this year it's 7%, and next year it's 9%. All of those negative adjustments could add up to be the cost of a part-time employee or even an upgrade to a software or some kind of technology in your practice. So we highly recommend at least avoiding that negative payment adjustment, and we're here to help. So please reach out for any support if you're wondering how you are going to be able to avoid this penalty. We laid out some reporting options that we thought we could mention. So the first option is, of course, do nothing, either not reporting entirely or earning fewer than 30 MIPS points will result in receiving a negative payment adjustment in 2021. Again, we highly recommend that you don't do that. We're here to help, anything you need. So the next option we're calling walk, which consists of earning at least 30 MIPS points, and that will result in avoiding the negative 7% payment adjustment in 2021. This can be done via a mix of measures or categories to earn those 30 points. The next option you'll see is jog. This option consists of earning anywhere from 30 to 74.99 points. Quality and cost must be reported on for the full calendar year, and improvement activities and promoting interoperability for a minimum consecutive 90-day period. This will result in a small positive payment adjustment. And the last option we're calling run. So clinicians or groups would earn 75 points or more, and for the same reporting period, quality and cost of full calendar year, improving activities and promoting interoperability, minimum 90 days, and earning 75 or more points will result in earning a moderate payment adjustment and an opportunity to receive that exceptional performer bonus. We've laid out some of the submission mechanisms for individuals and groups within each performance category. So I'll just briefly go through them. So for quality, for individuals, they can either do direct via their EHR or log in and upload, and that's via the QPP portal, or report via Medicare Part B claims. And it's pretty much the same for groups, although the CMS web interface can be used for groups of 25 or more eligible clinicians. For promoting interoperability, for individuals and groups, it can either be direct to the EHR or log in and upload, so that's uploading like a QRDA3 file, or log in and attest, and those are through the QPP portal. For improvement activities, again, for individuals and groups, direct through EHR, or log in and upload, or log in and attest. And then for cost, for individuals and groups, there's no additional reporting needed. CMS will calculate that all from your administrative claims. Okay, so now I'm going to go over some appropriate quality measures and improvement activities that could be applicable to the workflows of the 6 new eligible clinician types. So for audiologists, Quality ID 261, referral for audiologic evaluation for patients with acute or chronic dizziness, or Quality ID 91, acute otitis externa topical therapy, might be suitable for their workflows. Improvement activity that we found, improved practices that disseminate appropriate self-management materials might also be fitting for audiologists. For registered dietitians and nutrition professionals, Quality ID 239, weight assessment and counseling for nutrition and physical activity for children and adolescents, as well as Quality ID 128, preventive care and screening, BMI screening and follow-up will also be relevant to their specialty. An improvement activity, glycemic management services, might also be fitting for their workflows. For clinical psychologists, Quality ID 391, follow-up after hospitalization for mental illness, or Quality ID 107, adult major depressive disorder, suicide risk assessment, would be suitable for their workflows likely. And a couple of improvement activities they could report on, the depression screening improvement activity, as well as major depressive disorder prevention and treatment interventions might also be suitable. For occupational therapists, Quality ID 182, a functional outcome assessment, and Quality ID 109, osteoarthritis function and pain assessment, might be suitable for their workflows. And an improvement activity that might be good is enhancements to practice tools that include consideration for patients with cognitive disabilities. So that might be a good one for them to report on. For physical therapists, Quality ID 155, falls plans of care, and again, Quality ID 109, that osteoarthritis function and pain assessment might be applicable for them. And the improvement activity, implementation of fall screening and assessment programs might be a good one for them to report on as well. And lastly, for qualified speech and language pathologists, Quality ID 249, Barrett's esophagus, and Quality ID 467, developmental screening in the first 3 years of life, might be fitting for their workflow. And the improvement activity, cost display for laboratory and radiographic orders might be, tying in nicely with their workflow. So we've laid out a few strategies for success for these new EC types. So firstly, do you work with MDs or other eligible clinician types? Are you working in a group with other people who are reporting to the program, and can you report as a group? Does that make sense for your practice? If not, could you form a virtual group with others in your specialty? Talk to other clinical psychologists and maybe get a virtual group going so it might be a little bit more simple for you to report. And also check for bonuses that you might be eligible for. There's a 6-point small practice bonus. There's also 2 points for additional outcome measures and 1 point for additional high priority measures. There's also an end-to-end reporting bonus, so that's 1 point for each measure submitted using end-to-end electronic reporting. And I also do want to mention that the new eligible clinician types, audiologists, registered dietitians, clinical psychologists, OTs, PTs, and speech and language pathologists, they are exempt from the promoting interoperability performance category. So that 25% for PI automatically gets related to the quality performance category, making that category account for 70% of the total MIPS score. So I just wanted to mention that. Okay, so here we've laid out some cross-cutting quality measures and improvement activities that seem to be fitting for most specialty types. Especially for those new eligible clinicians, they might be looking at the measures thinking that not a lot of these apply to them or to their workflows. So some of these measures and activities really touch most specialty types and can be reported on by most clinicians. So like quality ID 47, care plan, or documentation of current medications in the medical record, or influenza immunization, or tobacco use screening and cessation intervention. Those might be good cross-cutting measures. And for improvement activities, collection and follow-up on patient experience and satisfaction data on beneficiary engagement, or engagement of new Medicaid patients in follow-up. IABE3, evidence-based techniques to promote self-management into usual care, or IABE15, engagement of patients, families, and caregivers in developing a plan of care. Now, getting ready for 2019, my colleague Tushara James is going to walk us through more detail within each performance category and offer more strategies for success.
Thank you, Kelsey. In the next section of the presentation, we will be discussing the scoring methodology and strategies to excel in the MIPS performance categories for 2019. Let's take a look into the quality performance category. Quality performance category measures healthcare processes, outcomes, and patient experiences. It comprises of the 45% of the final MIPS score in 2019. Eligible clinicians must report on at least 6 individual measures, including one outcome or high priority measure for a full calendar year. Specialists may also select a specialty-specific set of measures if applicable. Now, let's discuss the scoring methodology of the quality performance category. The sum of the points earned on reporting the required 6 measures and any bonus points divided by the maximum number of points, that is 60 here, times 45, which is the quality performance category weight, gives the total quality performance category score. Please note that the maximum number of points equals the total number of measures that is required to report times 10. In the next couple of slides, we would like to share some useful strategies and tips for the successful reporting of the quality performance category. First of all, try to report as much data as you can on as many patients as you can for the selected measures. The more data you report on, the probability of getting a higher score is high, even though your score depends upon the quality of data you submit. Next is to earn bonus points. You will receive 2 bonus points for each additional outcome or patient experience measure you submit after the first required measure, and 1 bonus point for any additional high priority measure you submit. Similarly, you can gain 1 bonus point for each measure submitted using end-to-end electronic reporting. If you are a small practice, 6 bonus points will be added to the numerator of the quality performance category if you submit data on at least 1 quality measure. And also, please keep in mind that no high priority measure bonus points for the CMS Web Interface Reporters for 2019. Similarly, measures that do not meet data completeness criteria will earn only 1 point, except for small practices which continue to earn 3 points. And bonus points are capped at 10% of the denominator of the quality performance category. In order to attain the maximum performance score for the quality category, here are a few more strategies. First and most importantly, choose the measures that are appropriate to your practice and patient population. Clinicians and groups can choose to submit a specialty or subspecialty measure set if available. In doing so, they must submit data on at least 6 measures within that set. If that set contains fewer than 6 measures, the clinician or group should submit all measures in the set. Next is to try to report on measures based on the activities or improvements you are already doing in your practice. So let's consider quality measure ID 236, that is controlling high blood pressure. That is percentage of patients 18 to 85 years of age who had a diagnosis of hypertension and whose blood pressure was adequately controlled during the measurement period. It is an easily reportable measure to many clinicians as most of the patient visits include blood pressure monitoring and potential follow-up visits for applicable patients. Another recommendation is to invest resources and time for robust data tracking tools and processes. Ensure that you track essential data to support the reporting requirements of the chosen quality measures. Similarly, it is beneficial to track data related to patient experience and overall care delivery. Target to score the maximum points in the quality measures. As mentioned earlier, CMS is maintaining the data completeness threshold of 60% for the 2019 performance year with a minimum of 20 cases per measure. CMS is also maintaining the 1-point floor for the measures that do not meet data completeness requirements except for small practices. That means you must report on at least 60% of your total patients who meet the measure's denominator criteria regardless of the payer. So that is Medicare and non-Medicare. And an exception for this is claims for which only Medicare Part B beneficiaries count. Last but not the least, keep an open mind and participate in the MIPS program not only to meet the reporting requirements or just to avoid a penalty, but also to identify the areas of improvement within your practice and understand your strengths and ways to optimize the performance as well as patient care experience. In this section, we will focus on the promoting interoperability or PI category, formerly known as ACI category, and we will discuss the basic reporting requirements, measures, and mostly on the strategies to maximize your performance and score. For 2019, PI category is 25% of the final MIPS score, and organizations and practices must use 2015 edition certified EHR technology. The PI category is geared towards improving access, sharing data, efficiency, and accountability. CMS is proposing a new scoring methodology in 2019, a smaller set of objectives and moving away from those base, performance, and bonus score measures that were used in the previous years. Each measure would be scored based on the eligible clinician's performance for that measure, based on the submission of a numerator and denominator, except for measures associated with public health and clinical data exchange objectives, which require a yes or no for submission. The 4 objectives of the PI category are e-prescribing, health information exchange, provider-to-patient exchange, and public health and clinical data exchange. Measures are no longer classified as base score or performance score measures. Each measure would contribute to the eligible clinician's total promoting interoperability performance category score. The scores for each individual measures would be added together to calculate the performance category score of up to 100 possible points. And there are opportunities to receive bonus points too. If an eligible clinician fails to report on a required measure or claim an exclusion, if applicable, the clinician would receive a total score of 0 for the PI performance category. Points will be reweighted to other measures when exclusions are applicable. For performance year 2019, you can apply for either the promoting interoperability hardship exception or extreme and uncontrollable circumstances exception. Some MIPS eligible clinicians, including the new EC type as Kelsey mentioned earlier, that are considered special status will be automatically reweighted and exempted from reporting from the reporting requirements of the PI category. To add, security risk analysis remains a part of the requirements for the PI performance category, but would no longer be scored as a measure. Please find the link on the slide to download the latest version of the security risk assessment tool. This slide explains the calculation of the PI performance category score. The total category score is the sum of the required measure score and bonus score divided by 100, that is the maximum number of points, times 25, which is the performance category weight. Here are some useful tips and strategies to maximize your performance in the PI category. First of all, make sure that you report on all the required measures, including the annual security risk analysis. Again, you need to have at least one patient in the numerator for all the required measures. Take exclusions when applicable. For performance year 2019, a 2015 certified EHR is required for the participation. There is also a minimum reporting period requirement of a continuous 90-day period. As you all know, the electronic health record systems are increasingly being deployed within healthcare organizations to improve the safety and quality of healthcare. However, to achieve these goals, the EHR must be used efficiently, and this remains a major challenge. We would like to recommend a few helpful hints to improve your EHR efficiency. Have a cross-trained staff that can handle intake and documentation. Training your staff is very important, especially after an EHR implementation or update. Another important point is to document encounters in detail without missing any necessary fields, and try to finish off all patient encounters, including documentation, at the end of each business day. Again, route documents appropriately and delegate effectively. That is, timely handling of the charts, faxes, lab orders, etc. Please keep in mind that inadequate documentation impacts both patient care and outcomes. As in face-to-face visits, clinicians providing advice by telephone must ensure consistent and full documentation in the medical record. During or immediately after a telephone conversation with a patient or a family member, notes should be made and placed in the patient's electronic medical record. It's very important to choose your EHR wisely. The EHR should be well suited for your practice needs and patient population. Always consider the cost, financial impact, and benefits expected in the short run as well as in the long run. Flexible templates, interoperability, and user-friendliness are also very important factors to consider. Cloud-based EHR is also an option where records may be able to be uploaded to the cloud, making them accessible from anywhere that has an internet connection. And make sure to opt an EHR system that can be customized based on your patient roles. Also consider ones which are capable and have options for easy MIPS reporting, for example, efficient data submission options like direct feature. Similarly, always aim for maximum category points. Consider reporting measures with bonus points. As mentioned before, annual security risk analysis is needed even though it does not earn any points. It is required to be conducted annually or every time after an upgrade or installation occurs. Failure to meet this requirement will result in a 0 score for the entire PI category. To add, consider conducting a CBA, that is the cost-benefit analysis, before an EHR implementation to assess the cost versus quantifiable and non-quantifiable benefits that are expected. Each practice or organization is different, so a meaningful analysis will be extremely beneficial to understand the affordability and future returns expected. In this section, we will focus on the improvement activities category or IA category, the basic reporting requirements, measures, and mostly on the strategies to maximize your performance as well as score. This category is geared towards increased accountability, patient engagement, and patient safety. It accounts for 15% of the final score in 2019, and there are 118 activities to choose from. There are two different weightages for the activities listed in this category. Medium-weighted activities earn 10 points and high-weighted activities earn 20 points respectively. Small practices and special status clinicians also receive special preferential scoring. The IA performance category score is calculated by dividing the total number of points earned for completed activities by the maximum number of points, that is 40, multiplied by 15, that is the performance category weight. In the next couple of slides, we will be providing some recommendations that might be helpful for the practices to achieve the maximum score as well as successfully report for this category. Always select activities or combination of activities based on your workflow. A thorough workflow analysis or brainstorming with a team will help practices to choose the most appropriate improvement activities to report on. Choose those activities that are easily reportable. To get full credit in this performance category, participants must submit one of the following combinations of activities depending upon your practice size or special status. 2 high-weighted activities, 1 high-weighted activity and 2 medium-weighted activities, or 4 medium-weighted activities. Each activity must be performed for a 90 continuous days or more during 2019. More than anything, keep in mind that this performance category is focused on identifying the possible opportunities for improvement within your practice and implement measures and interventions to achieve better outcomes. Always work with the team to redesign your processes and workflows to implement the selected activities. Another recommendation is to perform SWOT analysis, which is a very useful technique for understanding the strengths, weaknesses, opportunities, and threats your organization faces. It can be extremely beneficial for an organization to perform a SWOT analysis to choose the right improvement activities for MIPS reporting. Focus on overall care experience like wait times, check-in systems, and general processes, which has a direct impact on the quality of care. And in general, instill a culture of shared decision-making and patient engagement within your practice. Since improvement activities is an attestation-only category, it can be highly susceptible to CMS audits. CMS has the right to audit you up to 10 years. So make sure that you have detailed documentation available in accessible, safe locations. Here are a few examples for proper documentation. Let's consider the following improvement activities. IACC2, implementation of improvements that contribute to more timely communication of test results. Documentation can be EHR reports from a certified EHR or medical records demonstrating timely communication of abnormal test results to a patient. For IABE3, that is the engagement with QIN-QIO to implement self-management training programs, documentation can be documentation from QIN-QIO of eligible clinician or groups engagement and use of services to assist to it. That is, for example, self-management training programs like diabetes self-management program. And for IAPS-PA4, administration of AHRQ survey of patient culture, documentation can be survey results from the AHRQ survey of patient culture, including proof of administration and submission. There are some preferential scoring, flexibilities, and credit opportunities for this category. To be more clear, if you are a participant in a recognized or certified patient-centered medical home or comparable specialty practice, you will earn the maximum improvement activity performance category score by attesting to this during the submission period. For organizations with multiple practice sites, at least 50% of these locations must be recognized or certified patient-centered medical homes or comparable specialty practices to attest to this. If you are participating in the CMS study on factors associated with reporting quality measures, you will receive full credit in the improvement activities performance category. The participants need to submit the application form and successfully meet all of the study participation requirements to receive full credit. Again, you will receive double points for each high or medium rated activity you submit if you are an individual clinician, group or virtual group who holds any of these special statuses, that is small practice, non-patient facing, rural or health professional shortage area, etc. Last but not the least, tracking and measuring your progress periodically is very crucial. Schedule periodic reporting to check progress. Share results with your staff and document. It doesn't have to be very lengthy meetings, but can be even discussed during your weekly huddles. But communication is the key here. Change or update the processes if necessary. This will ensure your practice is correctly performing each chosen activity. Consider redesign or implementing new strategies to keep your efforts in the right direction. Again, as we all know, patient feedback or survey is another great tool that can be used to track the effectiveness of the implemented activities. Now, the cost performance category. Cost is an important part of the MIPS program as it measures the resource use and overall Medicare healthcare spending. For 2019, MIPS uses cost measures that assess the beneficiary's total cost of care during the year or during a hospital stay and or during 8 episodes of care. All clinicians and groups will be evaluated on the same 10 cost measures if they meet or exceed measures minimum case volumes. CMS uses Medicare claims data to calculate the cost measure performance. That means the clinicians and groups do not have to submit any data for this performance category. Now, MIPS scoring for cost category. The total cost performance category score is calculated by dividing the total number of points earned for cost measures by the maximum number of points multiplied by 15, that is the performance category weight. Please note that the maximum number of points equals total number of applicable measures times 10. Here are a few helpful hints to optimize your course as well as to attain the maximum score in this category. First is to verify your specialty and status. Check MPPS, that is the National Plan and Provider Enumeration System, to ensure the correct NPI numbers, that is the National Provider Identifier numbers, are listed. Regularly update PCOS, that is Provider Enrollment Chain and Ownership System, with the most recent Medicare enrollment information. Check Medicare's Physician Compare website to ensure that you and your clinicians are listed appropriately, as misclassification often leads to inappropriate allocation of patients and thereby wrong calculation of cost in general. For example, being misclassified as a primary care provider, if you are a specialist, will lead to patients being attributed to you inappropriately, resulting in an inaccurate calculation of your total per capita cost metric. More than anything, focus on value-based care and treatment strategies. Be proactive and provide preventative care to reduce unnecessary hospitalization. Follow evidence-based care and best practices and ensure effective and efficient treatment strategies are adhered to each stage of treatment. Now, MIPS scoring methodology. Under MIPS, each performance category is scored by itself. In general, MIPS final score is the sum of the individual scores of all performance categories. The payment adjustment assessed for MIPS eligible clinicians are based on the MIPS final score. The MIPS score and payment adjustment for the 2019 reporting year will take into consideration the following factors: the weighted value and performance results associated with each performance category, the exceptional performance factors, availability and applicability of measures for different categories of clinicians, and finally, the special circumstances of small practices and practices located in the rural areas, non-patient facing MIPS eligible clinicians, and other special scenarios such as performance category reweighting and bonus points. Here are some general strategies to succeed in the MIPS program. First is to know the program requirements and reporting requirements. Please visit the CMS Resource Library for QPP resources. CMS also has a QPP webinar library where you can find the past webinars with links and slides. Aim to become an exceptional performer to maximize your payment adjustments. Again, choose the right submission type, have a good know-how on submission options, costs, and limitations of each. Most importantly, have a valid HARP account, that is Hickers, Access Roles, and Profile System. CMS has updated and streamlined systems, replacing the old EIDM, that is the Enterprise Identity Data Management, with HARP system. Beginning from December 2018, new users who want to sign into the QPP portal need to create their account in the HARP system. If you already have an EIDM account and have verified, you can sign into the portal. If your EIDM user ID and password, you can stop there. You do not need to register for a HARP account. Another is to know the important deadlines like registration for CMS web interface, hardship exception application submission for the PI category, etc. Similarly, basic knowledge on how to access CMS QPP website, the portal, the CMS resource library, and QPP help desk are also essential for success. Finally, ask for help if you need. If you have any questions or you need assistance, we can help. Please visit our website for more information, and the New England QPP Service Center offers key resources to better your understanding of the MIPS program. Please find state-specific contact information of the experts who can answer your questions and provide several avenues in getting technical support via emails, phone calls, scheduled conference calls, webinars, and events. Now we are open for questions and discussion. Press #6 to unmute yourself to ask questions over the phone, or please type in questions in the chat. Or if you think you need more time and have multiple questions, feel free to email or call us. Our contact information is displayed on the next slide.
All right, great. So here's our contact information, our direct phone numbers, and our email addresses for anyone who either doesn't have time to chat over the phone or via the chat box, or would just like some sort of one-on-one, more personalized assistance. Feel free to do that. We have had a bunch of questions in the chat. Thank you all so much for asking such thoughtful questions. This is great. We're going to address them now. So we'll address all the questions that we have in the chat so far. So Marianne had asked if the new EC types need to apply for the PI exemption, the promoting interoperability exemption. And no, Marianne, they do not. It's automatically reweighted. Thank you. Eric had mentioned that we had spoken about the virtual group strategy for clinicians, and the designation for joining a virtual group ended December 31st, 2018. So when we were talking about it, we sort of meant for 2020 or for future years, because unfortunately the deadline has passed to join a virtual group for 2019. But thank you, Eric, for putting in that question. Brooke asked about as there were a new set of measures for optometrists or for the new EC types. So CMS has not released new sets of measures for the new eligible clinician types. And Brooke, you're right, some of those measures have retired, like the diabetes eye exam. However, the documentation of current medications in the medical records is still there. And I did check in the QPP CMS website. There is an ophthalmology specialty measure set, but there is no optometry measure set. If you need any more one-on-one help for you or your practice in selecting measures, again, please reach out to us. We're more than happy to walk through all of your workflows that you have and try to get you on the path for success. Next, Lisa had asked about the promoting interoperability. Will SHIR be necessary for 2018 or any API? Lisa, that's a great question. We are not positive. We know that it is important to comply to the HL7, the HL7 and CDA format that CMS would like clinicians to apply to, but I'm not 100% positive. So what I'd like to do is look more into it and get back to you with a certain answer on that question, if that's okay. And thank you so much for asking that. And I think Marianne had asked, can you attest to the same improvement activities 2 years in a row, or do you need to select different IAs each year? That's a great question, Marianne. So ideally, you would be reporting on different improvement activities each year. If you reported on the same one, CMS would sort of like to see, what are you doing differently than you did last year? How are you making an even bigger improvement in what you did last year? They sort of don't want to see folks doing the same thing year after year. They want to see change. They want to see improvement. So ideally, you would be reporting on different improvement activities each year. These are all great questions, and thank you everyone for asking them in the chat. I don't see any more in the chat right now, so if anyone wants to ask a question over the phone, it is #6 to unmute, and yeah, we'd love to hear your questions. This slide, oh, go ahead.
Here are a few helpful links. The link to our New England QPP website and link to Ask Your Question, where you can directly ask your QPP-related questions. Once we receive your question, we will definitely contact you with a response in a very timely manner. And the next is the link to the CMS QPP website and link to the CMS resource library.
Wonderful. Thank you all for such a great discussion. I do have a few last announcements before we end today's call. And again, we do have some more time for questions in the chat box or over the phone if you do press #6 to unmute yourself. But a reminder that we are now on social media. Please visit us on Facebook, LinkedIn, Twitter, and YouTube. When you close out of the webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. And if you don't have time to fill out the evaluation right now, or you're currently sharing your computer with someone else, you'll receive an email tomorrow with a link to the evaluation, as well as the link to the event page on our website. The PowerPoint presentation is posted on the website. Within the next few business days, a recording and transcript of this webinar will also be added. Again, I will post the link in the chat. And thank you again for attending, and have a great day. Pass this back over.
Thank you so much, Rachel. So yeah, if anyone has any questions in our last few minutes here, we're happy to answer them either in the chat or over the phone. And again, if not, I'll move back our slides to our contact information. You can always feel free to reach out via phone call or email. And thank you, Rachel. She just put the link to the PowerPoint there again, so you all can access the slides right in the chat box. Thanks, Rachel.